Hello everyone, welcome back to our channel Prostoshala, and in the continuation for the series of removable partial dentures. In the previous video we had already seen about the different procedures which we do, the pre-prosthetic as well as the prosthetic procedures, that is the mouth preparation for removable partial dentures. We have already covered the pre-prosthetic procedures. And then it's important to know about the various philosophies involved in the designing of removable partial denture, and then we move on to the preparation, that is the prosthetic preparation of mouth for removable partial dentures. I feel that is a proper order of understanding this topic in a correct way, right? So without much ado, starting with the philosophies of RPD designing, right? It can come as a 5-marker short note first of all in your internals or in your exams, right? Final exams. So when I talk about philosophies of RPD designing, right? Now there are two things which I have been already paying more attention on types of RPD, that is a tooth supported removable partial denture or a tooth and tissue supported removable partial denture. When I talk about tooth supported removable partial denture, the support is totally derived from the teeth which are present as the abutment or the remaining teeth in that maxillary or a respective mandibular arch. Now when I am talking about teeth or tooth and tissue supported removable partial denture, that means the support is derived from the teeth as well as from the tissues. Now these tooth supported, on which only the teeth are supporting the RPD, that is your Kennedy's class 3 situation. That means the edentulous area is bound by the teeth in front as well as in the back. So there is a single gap where the edentulous area is present, and those cases I considered it as a straightforward case. You can just take a single impression, that is an anatomic impression. Now again there are two types of impression, anatomic and physiologic impression. When I am talking about Kennedy's class 3, it is always a single impression, that is anatomic, because teeth are the areas or teeth, the abutment teeth which are present are going to provide the whole support for the RPD. So you need not worry about recording the edentulous area site in its rest form. Okay, you record it however you want. Ultimately the support which will be provided will be maximum by the teeth. But whereas in the areas where you have a tooth and tissue supported removable partial denture, that is your mainly Kennedy's class 1 and 2 and sometimes Kennedy's class 4. These have the support derived from the natural teeth as well as from the edentulous ridge. Now this becomes a complex situation where you have to record the teeth in their anatomical form and the tissues in their rest form, because Kennedy's class 1 is a distal extension edentulous area. That means on the posterior part there are no natural teeth present. Similarly for class 2 also. So in that case you require a physiologic impression which records the tissues in their rest form and the teeth in their anatomic form. So you need a combination of procedures where you are dealing with the cases of Kennedy's class 1, 2 and also to an extent of Kennedy's class 4. So keeping all these things in mind, there were various philosophies given by various dental experts. See, now how much which philosophy is valid, how much it is going to give you the results, the amount, that is the quality or the quantity of results, that is not yet proven. But any philosophy which is used with proper protocols and planning may give you the best results, right? So there are 4 philosophies, starting with your conventional rigid design, then you have stress equalization, physiologic basing and broad stress distribution. So these are the 4 main philosophies which you need to keep in mind when we are discussing about philosophies of RPD designing. So this was just a basic introduction for you all to dive into the topic. Now individually we are going to see what all these philosophies are saying, what are the advantages, what are the disadvantages, and how we are going to inculcate in our clinical practice when we are practicing cast partial dentures. So now first in the philosophies of RPD designing, that is the conventional rigid design. Now when I am talking about conventional rigid design, the name itself is saying that the design components of the removable partial denture, or to be precise, the cast partial denture, are rigid. All the components are going to be the rigid components in your cast partial denture. The only flexible component will be the retentive terminal. When I am talking about the retentive terminal, that means if we see a clasp of a cast partial denture, there are mainly two parts, the retentive arm and the reciprocal arm. Let this be the retentive arm, and over here the reciprocal arm. So the retentive arm has different parts, the shaft, the body and the terminal. Now when I am saying only the terminal, that means only this component of your whole clasp assembly is going to be flexible. Apart from that, any other component which is present in the cast partial denture is not going to be flexible. Coming on to the rigid components, when the components are rigid, they act like a raft, that is a strong foundation on which the parts of RPD as well as the missing teeth are going to be placed. So the rigid components acts like a raft foundation, and all the forces which are generated by the teeth, the other components of RPD, that is during the functional procedures or the functional movements carried out by the patient, all those forces are going to be distributed equally. Remember the term equally among the teeth as well as the edentulous area. So here the philosophy is that firstly the designing will be with the help of the rigid components. Moreover, when the components are rigid, the only flexible component is the retentive terminal of the clasp, that is the retentive arm, and other components acts like a raft foundation, right? In this scenario, if we consider the RPD or the cast partial denture which is made according to this philosophy, the advantages will be it can be constructed easily because you have a straightforward procedure. You did not take different impression techniques to record the tissues separately and the teeth separately, right? When we have that scenario like class 1 and class 2, you need to record the tissues in the physiologic form and the teeth in the anatomic form. But over here, however you record, the components are going to be rigid. So it can be constructed easily, it is economical, equal stress is distributed to the teeth as well as to the edentulous areas. No rotational movement will be present in these kind of rigidly constructed partial denture frameworks because they will have those indirect retainers which will prevent the rotational movement, and there are less chances of distortion, right? Similarly, as every coin has two sides, even the disadvantages are like there will be more amount of torquing forces because now you know the components are rigid. RPD is going to try to get dislodged, but it is going to be placed very rigidly in that area. So more forces will be there onto the abutment teeth that might damage them, and if you want to reline or do some modification in these kind of frameworks or design, it is a bit difficult to customize the removable partial denture. So this is a very short, very brief explanation of your conventional rigid design philosophy. Again, just keywords you need to remember: all the components are rigid, only component flexible is the retentive terminal. When the components are rigid, the forces directed will be equally onto the teeth and the edentulous areas. The rigid component acts like a raft foundation. Moreover, when you have understood this whole concept, it is easy to deduct the advantages as well as the disadvantages of the philosophy. Next, we'll move on to the various other three theories of your or the philosophies of removable partial denture design. Okay, so the second philosophy in the designing of removable partial denture is stress equalization. Now we already saw the drawbacks of the conventional rigid design, that is all the components which are present in the removable partial dentures were rigid. So there were a lot of forces, the unwanted forces which were acting onto the abutment teeth. Abutment teeth means on which your clasps are present. Now when that is happening, ultimately there is a damage occurring to the abutment teeth in terms of the periodontal ligament or the supporting tissues of those abutment teeth. Now always we have to overcome the disadvantages of the older philosophies and come up with a new one which is solving the problems more effectively, right? And that is why the stress equalization theory or the philosophy was introduced. Now here it is saying stress equalization. That means all the stresses are equalized in a proper way so that there is not much damage occurring to the supporting tissues or onto the edentulous areas. Now let's consider the situation in the conventional rigid design, right? These are your abutment teeth, this is your RPD with the denture base, the direct retainer or the retentive terminal. Now when the occlusal forces or the masticatory forces are subjected on this RPD, if the patient is chewing food and all the forces are subjected over here, there is edentulous tissues which are present beneath this denture base, correct? And secondly, there is periodontal ligament present around the natural teeth. Now the compressibility of your periodontal ligament and that of your soft tissue which is present beneath the denture is different. They are not going to compress at the same manner. The compressibility of periodontal ligament also gives the cushioning effect to the teeth, acts as a shock absorber, but not as good as your edentulous ridge, which is a full thickness soft tissue which can have more compressibility or less, that is subjected to the type of tissue. In that case, what was happening was to retain the RPD in the position, right? Because it's a rigid design, it is not going to move much. So the RPD used to retain itself by transferring all the forces to these retentive arm of your RPD, that is to the clasp arm. And this area, the junction between your denture base and the retentive arm, becomes a focal stress point where all the stresses are subjected, right? Ultimately what was happening? Damage to the abutment teeth. Now if I don't want this damage to occur, what I want is, I want the teeth component to compress at their own ability and the tissue component to compress at their own ability. So now when I want the teeth and the tissues to compress at their own ability, so I need to do something where the stresses are going to be equalized to the abutment teeth as well as the denture base area or the edentulous areas. That is where the stress equalization theory comes into the role. Now the remedy of the previous problem which we saw in the conventional rigid design is that there was no break between the retainer and the denture base. It's a direct connection, so the forces were directly going into the teeth. But now I don't want that. So what I am going to bring into the pictures is the stress breaker. We know about speed breakers, right? When you are going on a speed of 100, 120, suddenly you bump into a speed breaker, you reduce the speed. Similarly, there are stress breakers. When there is lot of stress acting onto the abutment teeth, we need something to break that stress from that junction, divert some amount of stress to the tissues and some onto the teeth so that it is balanced. And that is why we have used stress breakers. So stress breakers are the devices or the device which relieves all occlusal forces from the abutment teeth. Okay, abutment teeth. I want to relieve my abutment out of all the stresses. That is why I have introduced stress breakers. Now the RPDs which are made using stress breakers are called broken stress RPDs or articulated prosthesis. What are they called? They are called broken stress. The stress is broken in those type of removable partial dentures, or you can also call it as articulated prosthesis. Now when I talk about stress breakers, there are two types of stress breakers, type 1 and type 2. Again, stress breakers is a separate short note which might come as a 5 marker, where you need to start with the introduction of the stress equalization philosophy. You explain about stress breakers, that is type 1, type 2, and then you move on to the advantages and the disadvantages, right? So talking about type 1 stress breaker over here, this diagram, okay? Now I told you that this junction, the focal stress point, is the point where all the modification is going to happen. Everything else is going to remain the same. What they are saying is type 1 stress breaker, that is the junction between your DR stands for direct retainer, DB stands for your denture base. So this is your clasp, which is blue in color, red signifies your denture base. Now this junction between your clasp and the denture base, the focal point which we are talking about, right? If I give a ball and socket joint or a hinge joint over there, right? Ball and socket like this, a ball in the clasp and a socket in the denture. Now what happens is, when the force is directed on the denture base, because it's a ball and socket joint, it is going to compress on its own ability, and the force is directed to this direct retainer or the retentive arm or the clasp, whatever you call, will be less compared to what we're acting in this situation. Now because it's a hinge joint, you have broken the connection between the denture base and the clasp assembly by giving a joint like our elbow joint, right? So all the stresses is broken, so they both can move at their own pace. It can be a hinge joint or a ball and socket joint. Examples are Dalbo, Crismani, ASC 52. The mnemonic is CAD CA, D is the mnemonic, right? Crismani, ASC 52 and Dalbo. Now this was all about your type 1 stress breaker. Now moving on to the type 2 stress breaker over here. It's almost the same, again concentrating on the focal area, that is the junction between the direct retainer and the denture base. Now here the junction is such that there is a separation. You see a white area between the direct retainer assembly and the denture base assembly. Now when there is this separation, again the direct retainer assembly is relieved of all the forces which are coming from the occlusal direction onto the denture base. Imagine denture base getting compressed like this, but there is a connection, so it will compress on its own rate. Here the forces to the abutment again will be less. So this is not a ball and socket joint, but it's a flexible connection between your, again, the DR and DB component. DR stands for direct retainer, DB for denture base. Flexible connector, or you can also call it as a split major connector. It is split in between, there is a slit over there which is separating the denture base and the direct retainer assembly. So this was your type 2 stress breaker. So again, RPD designing, stress equalization theory, stress concentration, the focal stress area causing damage to the abutments. The remedy is stress breakers which can break the stress, so they are called as broken stress RPD. Type 1 stress breaker, which is a ball and socket or a hinge joint. Type 2 is a flexible connection which is called as a split major connector. Now we have seen both the type of stress breakers, that is your type 1 and type 2. But when I'm saying that there are always, as I said in the previous theory also, it will have disadvantages and advantages both, right? So when we are looking on to the advantages and disadvantages of the stress equalization theory, let's go on with the advantages. What are the advantages? Obviously the disadvantages of the previous theory or the philosophy becomes the advantages of this theory, right? So first point should be always the stress is equalized between what? Between the tissues and the abutment, right? Secondly, less damage, or you can say no damage to the abutment teeth. Stress equalized in both the denture base and the abutment area, less damage to the abutment teeth. Okay, the life of the abutment teeth is increased. Okay. Secondly, more functionally stable. More functionally stable. You don't have to think about the vertical forces which are acting onto the RPD, right? But above all the advantages, there are few disadvantages also. Suppose this stress breaker can only resist forces from the vertical direction. What about the rotational torquing forces which are acting? Those forces are not going to be limited by your stress breaker or stress equalization theory. So again, when there are more rotational or torquing forces acting onto the RPD, there are more chances that there is again unequal or unrequired forces on the abutment and onto the denture bearing areas or the residual ridge, leading to resorption. Secondly, you want to modify, repair. It's a very thin connection, right? It might break. It is subjected to breakage. So repair is difficult, relining is also difficult. Again, these joints are not very cheap or cost friendly. They are very expensive and you need to have a tedious, laborious work to install these or include this in your RPD designing. So this was all about stress equalization theory. Okay, see you in the next theory.